Welcome to week number 3. Now we're talking about cooking a kid, right? Care during pregnancy. So we're back to the beginning of the story. Who's had a baby? Did you know you were pregnant, like right away? Because of like whether it was nausea, whether it was tinglies, whether it was hormonal like PMSy like symptoms, right? There are definitely some signs that maybe only you can tell, right? But before you start showing, you definitely know you're pregnant. So we kind of break down the signs of pregnancy into 3 specific categories. The first is presumptive. All right, presumptive signs are subjective. So it's what's felt by the pregnant woman herself. So that could be nausea, right? It could be that she's peeing all the time. It could be we call quickening, which is actually like a flutter. It's only felt by the woman. It's not movement that a person can feel on the outside. It's just that fluttery gas. You're not sure it's gas or a kid. I had some quickening yesterday. I'm going to go with gas. Sorry, that was completely inappropriate. But now you remember quickening, right? All right. So felt by the patient could be something else. Then we have probable signs. Well, now we're narrowing it down to a couple of different possibilities. But it's still not 100% that it's pregnancy. All right? This includes a pregnancy test result of positive. Because it could be a hormonal thing, it could be medication. And did you know that if a man tests his urine and gets a positive pregnancy test, that's a sign of testicular cancer? Yeah. So, see what I'm saying? A positive pregnancy test is not necessarily an absolute that it's pregnant. Nor is a negative pregnancy test mean they're not pregnant. So that's why it's considered probable and not absolutely positive sign. The absolute positive sign is diagnostic. It is truly the diagnosis, official diagnosis of pregnancy. We can go through all of these different things, which we kind of already did. A couple that you might not know about, and these are because it's objective signs. This is the probable ones, right? Probable signs are objective, which means the practitioner might be the one that's discovering it, all right? Hagar's sign is a softening or compressibility of the lower uterus. So somebody's in there poking around. They can feel the difference. Chadwick's sign is a bluish color of the cervix and vaginal mucosa. So clearly somebody else sees that. And Goodell's sign is a softening of the cervical tip. Again, during a GYN exam, this is picked up. These are objective signs. Absolutely positive signs of pregnancy, diagnostic. Visualizing that there's a fetus by ultrasound. That's pretty positive, that there's a baby in there, right? If you see it. If we can hear fetal heart tones, if I, as a practitioner, could put on the little ultrasound Doppler thing, and you hear boom, 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 and I feel mom's pulse, and it's not mom's pulse. It's different. That's a positive sign because there's nothing else that can sound like a beating heart other than a beating heart. Maybe there is, but that's a movie, a horror movie or something. I don't know. If I can feel the baby moving, not the patient, but if a nurse or a practitioner can actually feel fetal movement, that's not gas. That's a baby moving. See the difference between the 3? Subjective, objective, absolutely cannot be mistaken for anything else. Positive. Now, we do have some pregnancy tests that again fall into the probable because it could be a hormonal thing. But we have urine tests, which you can buy in the grocery store. You can buy probably at the 7-Eleven. I don't know. I'm not in the market for them. I don't know. But they're pretty sophisticated these days. And then you have a blood test, which the doctor can order. Both are picking up on a level of human chorionic gonadotropin, the hormone, the pregnancy hormone, basically. All right? The serum can be qualitative or quantitative, actually. Quantitative gives you an actual level, like a number level of the HCG, whereas qualitative is just positive or negative. Now, the reason why it's still considered probable is because very high levels of HCG, you think, I'm really pregnant. But it's not necessarily a good sign. It could be actually a sign of a molar pregnancy. It could be a good sign in that you got more than one kid in there. Or maybe you're further along than you expected. But again, some medications can cause false positive or false negative. These pregnancy tests that you buy are, like I said, they're pretty sophisticated, very sensitive. You can actually detect the level of very low levels of HCG with these urine tests. And about do I have it on here? Like 10 days after conception, which is before you even miss a period. So that's pretty sensitive if you ask me. For those people who are trying to get pregnant, they're probably starting those pregnancy tests. Roll over and start the pregnancy test. But they should wait at least 10 days. And if it's negative, but they really feel like they're pregnant, maybe they've had some subjective signs, some presumptive signs that they're pregnant. They know their bodies, but the test keeps coming back negative. Wait a little bit and take it again. Maybe it's just too low a level until it becomes positive. So all we need, when you tell somebody I'm pregnant, what's one of the first questions they ask? When are you due? Okay, well, here's a little tip for your next gathering, social gathering, a little party. Well, at my parties anyways. All you need to give me is the date of the last normal menstrual period. I'll give you your due date. Try me. Huh? You don't need any fancy app on a phone. You don't need any fancy little pregnancy wheel thing that you're just going to see all over the units. All you need is the date of the last normal menstrual period. From there, you're going to subtract 3 months. And then you're going to add 7 days. And then you're going to add 1 year. All right? Let's do that.
Sounds like quite the party.
Huh?
Sounds like quite the party.
Isn't it? Again, my parties. Okay. Yeah. Good food and due dates. All right. Last normal menstrual period, May 10th, 2014. So what are we going to do first? We're going to subtract 3 months. What does that bring us to February? February 10th, 2014. We're going to add 7 days. February 17th. And then we're going to add a year. So February 17th, 2015. Right? Sound reasonable? All right. Say that say last normal menstrual period was in January 17th. Subtract 3 months. October of the year before. Keep that in mind. So when you go add a year, don't make a person pregnant a year and 9 months, because you're taking that 3 months back into the year before. So when you add that might come up. I don't know. Maybe it'll come up at the party. It might come up. They do have pregnancy wheel apps on phones, as well as very cool, I think, because I'm a dork. Because those are the kind of parties. These are actually what we serve the apps on. Appetizers. All right. The reason I think these are cool is that you can take one date, a due date, a last menstrual period, something, and you move this inner circle, and then you go to whatever date you're looking at. Maybe you want to say, when am I going to be 20 weeks pregnant? All you have to do is align that up, and you can get the specific date of when you will be 20 weeks pregnant. Or you can say, how many weeks pregnant is this patient? Set it up. What's today's date? Okay, she is 32 and 3/7 weeks pregnant. So, I don't know. It's pretty basic tool, but can give you a lot of information.
What if they have a very irregular period?
That screws it up for I mean, I'll still have a good time at the party, but a little bit harder to figure out. Some women say, well, I had got my period last week. Well, I can't possibly be pregnant. Well, how was that period? Well, it was lighter and really just kind of spotty a little bit. Was that a normal menstrual period? No. So the last normal menstrual period is a key. But if you don't have normal menstrual periods, then you need to figure out another way to confirm your pregnancy, which is usually an early ultrasound. And an early ultrasound within the first 6 or 7 weeks of the pregnancy is usually very accurate in determining a due date. All right. Technically, a pregnancy, because we use the date of the last normal menstrual period, that's actually 2 weeks before you get pregnant, right? And then there's another 2 weeks where you might not know you're pregnant, but then you miss your period, you start, all right? So a pregnancy is 40 weeks. It's actually 10 months, but we always think of a pregnancy as 9 months. It's because of those added couple weeks in the beginning, okay? Does that make sense? So we divide these 40 weeks into 3 trimesters. Last one being a little bit longer. All right, some common terminology that will help other like reading the chart and reading the information in the book will help to make a little bit more sense. All right, we use Latin a lot in medicine, and OB is no different. So common terminology we need to consider is partum. Partum means, let's just think about it. It's the baby parting mom. Partum is the actual delivery, all right? So antepartum is before the delivery, before labor. Intrapartum is during the labor and delivery part. And postpartum is after the delivery. All right, gravida, we briefly discussed in the first week. Gravida is the number of pregnancies a woman experiences, has had. All right? It doesn't mean the number of deliveries. It's just the number of pregnancies she's had. Nulligravida means she's never been pregnant. Primigravida, this is her first pregnancy. Multigravida, she has had more than one pregnancy. Grand multigravida, or something like that. It's my great-grandmother. That's not up here. A lot of pregnancy. Para is any pregnancy that actually has reached the 20-week mark or more. All right? Now, we had a patient the other day. She's gravida 10. Para maybe 5, maybe 6. It was a little sketchy. The history was a little sketchy. But we had about maybe 4 or 5 pregnancies that weren't accounted for, or that we didn't. The difference between the number of pregnancies and the number of living children was off enough so that we're like, what happened to the rest of those pregnancies? And it doesn't. This para business doesn't really tell the whole story. So just to confuse you a little bit, we break down para into TPAD in the next slide. In fact, I have to go right to that slide. T-PAL. T-PAL is para expanded to tell more of the story. All right? T is the number of births at term. So 37 completed weeks and above. P are the number of preterm births, and that's 20 weeks to 37 weeks. A are abortions, whether spontaneous abortions or induced abortions, or ectopic pregnancies, any pregnancy that ends before the 20-week mark. And L are the number of living children from all of that. All right? So you're going to count, hopefully you're going to count a term pregnancy, you're going to put a 1 in that category, and hopefully you're also going to put a 1 in the L category, because hopefully the term pregnancy resulted in a living child. All right? We'll have some examples of that momentarily. I am going back to the slide to talk a little bit about this para business. If we're calling a person nullipara or nullip, we shorten it. That's somebody who's never had a birth after 20 weeks. All right? Doesn't mean they haven't been pregnant, unfortunately. All right? Primipara this is her first delivery after 20 weeks. You will hear on the units, oh, a primip is coming in. That means we have somebody coming in to have their first baby, which might give us a little understanding about the patient and her situation. Multipara, or multip, is somebody who's done it before, at least once. Grand multip is somebody who's done it numerous times. 2 ways to describe the women. The gravid and para. Let's tell more of the story. We move on to T-PAL. So the P of T-PAL is preterm. If you just saw GP with 1 number after it, that's not this P. That's where it kind of gets a little confusing. All right? If you see G4P1, that means 4 pregnancies, 1 delivery after 20 weeks. If you see G4 P3104, I know. If you see it expanded out to 4 numbers after the P, it's these, yeah.
So
All right.
I think we had a discrepancy today with that.
Hmm?
It was G3P101, so it was missing a number, right? Is that,
It's missing a number and it's missing a pregnancy.
so is that just an error, or,
Yes.
okay,
Um,
I don't think we ever.
but
really-
when you see it written down, like on the patient's chart at the hospital, most of that information comes from the prenatal record and stuff, and it's before the delivery. So it's missing the outcome of the current pregnancy. Or if you're taking care of the patient postpartum, the information filled out prior to delivery is what you're seeing, and it doesn't include the current delivery.
She's G2P1 still.
Yeah, but, yeah.
She's really.
G2P2, yeah. So if you see P with 4 numbers after it, it's para broken down to tell a little bit more of the story. The confusing part is that there's a P here too, and you're like, whoa, what's that about? 2 separate Ps. Somebody should have thought of that. Sorry. Okay, let's do this out. This woman has a son who's born at 39 weeks. So that's, well, I should get a, does anyone have a, I should get a,
Whiteboard marker?
yeah.
She has one.
Who does? Whoa. Note that she is prepared. All right. So don't look at the answer. All right. So this woman has had a son born at 39 weeks. So we're gonna put it on G, right? And then we have T-PAL underneath it. So son at 39 weeks, she's had one pregnancy, right? 39 weeks, we're gonna put one under term. And she has a son, so it's a one under living child. Cool. Then what are we talking about? Baby born at 30 weeks. All right, so that was a pregnancy. It's under preterm. Later we find out she has 2 living children, so I'll just put living children. Then she had a miscarriage at 8 weeks. Do we put it for G? Yeah, we put it for G. And then A. Because A is miscarriages, abortions, ectopics, any pregnancy that ended before the 20-week mark. And an induced abortion at 4 weeks. Is that G?
Yes.
And then it's also A. And it confirms she has 2 living children. So that's gravida 4, para 1122. I know. Para expanded to T-PAL. Now, if she came to us with this history, but also said, I'm pregnant again, we would add 1 to gravida, but we don't know yet the outcome of that pregnancy. So she's got 1 more G than she has P's, I guess, because we are still waiting for the outcome. Thank you. I think there's more examples in your book. There's certainly more examples, not on my YouTube channel, but there's definitely, just giving you a little. Maybe I should put some up there, huh? Would that get more subscribers? All right. Does that kind of make sense? Yeah? So if P has 4 numbers after it, it's para broken down to T-PAL.
What were the number of weeks for preterm?
Sure. Number of weeks for preterm is 20 to 37. All right? Term would be considered the end of the 37th week to 42, 45, whatever. Whatever.
When you say end of the 37 weeks, is there a certain date that you're?
37. So preterm is if she's 37 weeks and 6 days pregnant, she's still considered preterm until she hits the 38-week mark. All right. I promise I won't ask any questions that are right on the border like that. That's too detail focused for even me. All right. All right. So we're pregnant. We know we're pregnant. We know how many times we've been pregnant and all that. Now, remember a couple of weeks ago, I started talking about all the things that the woman had to do in her body to get back to her pre-pregnant state? Well, we have 9 months, or 10 really, right? To figure out, to get to that full-term pregnant state. So there's a lot of changes that occur over those 40 weeks that we're going to talk about. We're going to break it down into their systems. Reproductive system clearly will undergo plenty of changes. The uterus, estrogen helps increase the size of the uterine cells. All right, that uterus goes from 10 milliliter capacity to 5,000 milliliter capacity. And if you didn't think women were superheroes, I would hope by now you would. An organ within her body increases by, 500%? Wow. And grows another human being. Wow. It's primarily due to the current cells that just get bigger, hypertrophy of current cells. Some are added as well, but primarily it's just the current cells getting larger and stretching. Cardiovascular wise, a whole lot of work. In fact, some women with underlying cardiac issues that never gave them trouble before might give them trouble during pregnancy because the heart takes on quite an extra bit of work, all right? If somebody has a cardiac issue, most likely the obstetrician will strongly encourage, if not require, a cardiac consult just to clear them for pregnancy and method of delivery. Because there are some with certain cardiac issues that should not go to term because too strong a load on the heart, or should not deliver vaginally. The pushing might be too much of a stress, whatever it is. So cardiac consult because of all these changes. The actual heart grows in size because it's got a whole lot more going on. It has to meet the demands of the pregnancy, which is, and support the growing of another human being. So it's no surprise that a pulse might increase a bit, right? About 10 to 15 beats per minute higher. It's got a whole lot more blood and it's being rerouted to different areas. All right? Now, think about it. We got a baby growing. It's getting heavier and heavier in this uterus right here. Depending on like positioning and stuff like that, all that blood in the lower extremities might have a little bit harder time getting up past the whole circus of the belly, right? So have you ever heard about a pregnant woman having puffy feet? That's because it's taking a whole lot of extra to get that blood circulating from the lower extremities. You ever heard of a woman having varicose veins in pregnancy? How about hemorrhoids? Hemorrhoids are varicose veins and in a very unfortunate location. That's all. It makes more sense if you think about it that way. You've got this extra weight and activity going on right here, so the lower extremities, it takes a little bit more, and sometimes we're not very successful at it. All right? Blood volume, and I mentioned this our first week also. Blood volume by the, about the 30th week? Yeah. That's where it peaks. 50% higher blood volume. 1.5 times non-pregnant amount of blood. Wow. All right, 2/3 of that extra blood are plasma. So the blood is a little more diluted than before. So that's why we are a little bit easier on the anemia guidelines or standards, where a non-pregnant woman would be considered anemic if her hemoglobin is less than 12. When they're pregnant, considering the blood is a little bit more diluted, we wouldn't start treating anemia until the hemoglobin is less than 11. So it's just because we're taking into account this hemodilution. Have you ever met a pregnant woman who felt like she couldn't take a deep breath? Right? Well, imagine me with about 14 inches of torso, growing a baby, and there's only just so much room, right? So we're pushing up on a diaphragm, and you really do feel like you can't take a deep breath because you're getting, kind of cramped. It's getting kind of cramped in there. The chest circumference actually can increase up to 6 centimeters simply so we do not lose the intrathoracic volume, all right? So it expands out this way so that we accommodate for the growing baby below. We got a whole lot more blood to oxygenate, so between the expansion of the chest, we are also supplementing that with breathing more, meaning the volume of air that we breathe. We eventually will change how we breathe as an adult from abdominal breathing to chest breathing, because there's no way that anybody sing here, like professionally or anything. All right. Well, they always talk about belly breathing. It's because they want to expand the diaphragm, and so it feels like you're breathing out of your belly. It's because you're expanding your diaphragm. Well, if there's a kid in the way, you can't expand your diaphragm downward, so it has to be up in the chest. Does that make sense? So you can't breathe down here. It's all up here. Your basal metabolic rate increases too, 15 to 20% by the end of your pregnancy. So you got a lot of extra blood rushing around. You have a little bit sluggish return of the circulatory system. Some women have nasal stuffiness or bloody noses, bleeding gums, that sort of thing. It's just because that extra blood volume kind of making things a little puffy and swollen and to the surface. Vascular congestion. You ever seen a pregnant woman walking in the grocery store? You don't see her pregnant belly, you just see her from behind, but you know she's pregnant. That waddle of pregnancy, right? Or the hand on the back. Sometimes I go to the grocery store, actually, and just mimic that and see what people are like, oh, I thought she was just fat, but maybe she is pregnant. No, she couldn't be pregnant. She's much too old. I can do it. I can do it. Just kidding. Joking. Lordosis. Lordosis is the curvature of the spine, lower spine, to accommodate the growing weight of the front of the belly. All right? That's what we see. We see that in the waddle of pregnancy, which is just our hips expanding a little bit and relaxing to accommodate the growing weight of the belly. Who had sciatic issues during pregnancy? Oh, gosh, God bless you all. God bless you all. Not a very little we can do about it. It's an instability of the sacroiliac joint. And all the extra pressure and stuff like that. It's no surprise that you have problems with sciatic nerve. All right. Sometimes some gentle stretching helps, but you can't take ibuprofen during pregnancy, so you're kind of out of luck there. Acupuncture? Did you do that? That's awesome. Decreased muscle tone is an issue. Some women experience a split in their abdomen. The rectus abdominis muscle splits open a little bit. It's called diastasis recti because it doesn't actually, it's not busting open or anything, but it's the seam where the two muscles are joined in the middle that just separates a bit. I promise you're not going to bust wide open, even though you might think you are. There is the beautiful lordosis of pregnancy. For anyone who needs the example of that alive and in person, follow me to Price Chopper after. I'll give you a demonstration how to fake a pregnancy. You're just fat. Keep them guessing. Keep them guessing, folks. All right. GI. Lots of GI stuff going on. Morning sickness? Anyone? Why do they call it morning sickness? Anyone? Huh? Yeah. Anyone? We need to change that. We need to change that up. Let's call it just sickness. Yeah. Baby sickness. Pregnancy sickness. I don't know. Something. But morning sickness makes me feel like there's something wrong with me because I just threw up in the afternoon or whatever, you know? Or that you, or for some reason, have it worse than everyone else because it didn't stop after noon. It kept going. I love after the first trimester, it goes away. Huh? Not here. I had like a month and a half at the end of the between the second and third trimesters where I might not have thrown up all that much. And then the end of the pregnancy came, oh, try laying down, right? Whoop-ah, you're like, woo! Everything kind of comes back up on you. Yeah, running out of room for the stomach too. Doing that and the relaxation of your esophagus and all sorts of things. It's no surprise that there's a little regurgitation happening. Initially, this morning sickness, they say is probably due to HCG levels. Who had heartburn during pregnancy? Ay, ay, ay. Early in pregnancy, the progesterone and all of that actually will, did I have it on this slide? Oh, see, sorry, I don't pay attention to the slide. There we are. The esophageal regurgitation. What happens is you have decreased tone in your esophagus, and due to the high levels of progesterone, which is a muscle relaxant, which is supposed to happen because you want other muscles to relax, but it's not specific. So the decreased tone of the GI tract can cause heartburn early in the pregnancy.
So it has nothing to do with if the baby has a lot of hair.
No, not at all. What it has to do with is hormones. At the end of the pregnancy, it's running out of room, and a baby giving you a good old whack in the stomach that just like pushes the acid out of your back of your throat. It's pleasant, beautiful time. For somebody who says, my baby's going to have a lot of hair, and then they, smile because they're going to have a baby with a beautiful head of hair, just let them. Just let them think that. Oh, yes, that's true. It justifies the heartburn. It's a universal myth that seems to cross all cultures. Just let them think that, right? Oh, yes, and this baby's going to be gorgeous, right? Have a Tums. There's nothing to it. All right. We got constipation. If the heartburn and nausea weren't enough, constipation, throw that in there, right? Again, decreased GI motility. How about prenatal vitamins, all right? The iron in the prenatal vitamins or whatever. All of that make constipation a common complaint amongst the pregnant women. The increased capacity in the whole GI system might cause some trouble with people's gallbladders, all right? In fact, a lot of women either have gallbladder issues during pregnancy or right shortly thereafter. I've heard of a lot of women within a month postpartum having to have their gallbladders taken out. It's because of just the increased activity in the GI tract. The liver should have very little changes. All right. Now, bladder-wise, initially, because people say, "Oh, I knew I was pregnant because I was peeing all the time." There's just a whole lot of activity going on down there, and the bladder shares a space with the uterus in the pelvis. So that's why there's. It seems like, you are peeing a lot because I think the uterus is because there's so much activity in that pregnant uterus with the increasing blood flow and excitement of pregnancy. It just kind of bullies the bladder that can't hold enough urine as non-pregnant. The second trimester, if I can have a favorite trimester, that would be it. Because in the second trimester, you start looking pregnant, right? That's because the uterus has grown enough so it actually becomes an abdominal organ. It's no longer like hidden within your pelvis. So you start looking pregnant, but you're not so large that you're uncomfortable. You're just cute, right? And your bladder finally has a little extra room. Your bladder's not being bullied by your uterus anymore. So for a little while, you actually have more than an hour's worth of capacity in your bladder, which is nice. third trimester comes along. Towards the end of the third trimester, baby drops back down, and you no longer have bladder capacity. Now you're getting up every 45 minutes to pee because the baby is just pressing on the bladder. There you go. Because of all this decreased tone, decreased space, hyperemia, if you will, lots of blood flow to the area. A pregnant woman is a little bit more at risk for UTI, so just pregnancy doesn't protect them from getting UTIs. Pay attention to that. When the everything kind of shifts and moves and all of that, the bladder gets actually pulled upward with the uterus. Not as far up, but certainly does get pulled upward. In doing that, the urethra actually increases in length up to like 7.5 centimeters. That's pretty impressive too, isn't it? And how we can accommodate all this change in the body.
Does it go back to normal after you have the baby?
Yes. We'll call it the new normal. As long as you're doing your Kegel exercises. Takes about a week for bladder tone to return to normal. So I already just said all that. There it is again. I wasn't lying. Then you have your endocrine system. It's all about the hormones. In fact, the idea of the hormone involvement to me, I'd rather just say it's magic because that is not as overwhelming, to be honest with you, as thinking about the whole hormonal system and all the different hormones that are connected and in charge of different things, and it all like a busy 5-lane highway with 3 other highways merging into one place. To me, it's potential for accidents. Anyways, so it's magic. How about we just go with that? Well, probably not. We should probably talk about the fact that the thyroid gland is in overdrive, all right? It actually increases the basal metabolic rate 20 to 25%, so it will enlarge. Lots of different functions of hormones throughout childbearing and menstruation and that sort of thing. Early in the pregnancy and prior to the pregnancy, you have your follicle stimulating hormone, your luteinizing hormone, which pops the egg off, right? Sends it down to meet up with their date, the sperm, right? Prolactin kicks in after birth to help with milk production and the letdown of milk. Oxytocin, we know all about oxytocin, right? And pitocin, all those math tests. Oxytocin helps with breastfeeding and milk letdown also. Adrenal glands, major increase in circulating cortisol, all the metabolism of protein and carbohydrates and all of that sort of thing. Progesterone is big in helping with smooth muscle relaxation. We want smooth muscle relaxation, particularly the uterus and the pelvic muscles. So progesterone is really important to maintain the pregnancy, and I think it's because the uterus naturally wants to contract when it's feeling like it's being invaded. So progesterone helps relax everything so that it will maintain the pregnancy. We have placental hormones. So once the placenta forms and is implanted, we have human placental lactogen. This is actually an antagonist of insulin so that the baby will grow. I think this is the cause of gestational diabetes. It makes sense, doesn't it? Estrogen is important, certainly within the menstrual cycle, but also just in maintaining the pregnancy. Another hormone, particularly important during pregnancy, is called relaxin. Relaxin is relaxing everything. It's relaxing the muscles and tendons and joints. We want them to relax the abdominal muscles, the uterine muscles, and the pelvic joints to accommodate the growing size of the uterus, as well as the passage of a large baby through the pelvis. The problem is it's not specific. It's not specific just to that area. So a woman's more prone to joint injury, carpal tunnel, sprained ankles, ACL, all sorts of things. If they're trying to, and that between that and they're changing, they're shifting center of gravity, it's no wonder some people, sprain their knees or ankles or whatever during pregnancy because of this relaxin hormone and the clumsiness of pregnancy. How about a woman who maybe is recovering? I'm calling her a recovering anorexic. Or how about a woman who lost a whole bunch of weight, an extreme amount of weight, whether it's through surgery or extreme diet and exercise? How do you think that woman might have a little trouble during pregnancy? Even though she's over it, right? Oh, that was 20 years ago. But she's all of a sudden feeling out of control about her body, in terms of body image. So knowing a woman's history, whether her mental health history or her surgical history or just her weight loss history, might come into play as the body changes. All right. So some women might have difficulty, and we just need to pay attention to that. How about, we were talking about this last week in my Friday group. How about the fact that some people have no boundaries when a woman's pregnant? They actually touch a woman's belly without asking permission, right? Or when you have a baby, right? Kissing, touching your baby. Like, I don't know what makes, they're just so overwhelmed with the wonderfulness of it. I get that. But if I'm already having a little problem with my body image or struggling with that, and a complete stranger comes up to me at the deli and touches my belly, I might have there might be other problems. We'll just say that. There's challenges, on a serious note. Oops.
Your time's up.
My time is up. We'll talk more about the next slide. Ooh, all right. We'll talk about skin changes next. Do you need a couple minutes break? Or are we just stopping this and starting over again? Keep going, folks. Keep going. Hi.